the Spoonie struggle. This is your host, Jessica. I'm a neuropsychologist and longtime Spoonie with Ehlers-Danlos, POTS, and a whole host of other syndromes. This show is about the raw, honest look at living life with chronic illness and pain, especially those that are difficult to diagnose and less well-known and understood. Full disclosure, any information discussed in this podcast is strictly the opinion of the host and of the guests and is for informational purposes only. It is not meant as medical advice and should not be taken as such. Always consult with your doctor and medical team. Living with chronic illness can be hard. If you ever find yourselves or someone you love in crisis and need someone to talk to, you can always call the National Suicide Hotline Support Lifeline at 1-800-273-TALK. They offer free and confidential support in the USA 24/7. And now, the Spoonie struggle. Hello and welcome to the Spoonie struggle. This is your host, Jessica. Today we discuss making ER visits more smooth sailing for Spoonies. Today we have a special guest. Dr. Harvey Castro is an emergency room physician and healthcare leader who thrives on motivating teams by providing the most technologically advanced healthcare services to local and outlying communities throughout the state of Texas. His passion is in balancing innovative healthcare approaches with individualized patient care. He believes in building sincere trust with patients, doctors, staff, and community leaders by displaying unwavering compassion, care, and understanding. He has been voted Best Doctor consecutively each year since 2014 by D Magazine and is certified by the American Board of Emergency Medicine and American College of Emergency Physicians. He is frequently in the media and serves as a speaker to healthcare organizations and practice groups to inspire loyalty, drive compassionate patient care, and build professional growth. Welcome, Dr. Castro.
Thank you for having me. I'm excited.
Oh, I'm really excited to talk to you today. And before we got started, I actually shared that every guest that we've had so far has talked about their ER experience and how they, to be nice, would like it to have been different. So I am super excited to speak with you today because it is so important that we have these conversations. So I feel very, very grateful that you're here.
Well, I'm excited to be on here. I think as an ER board certified physician and being the president of Trusted ER, I have a lot to say and a lot of insightfulness into the subject.
Absolutely. So tell us a little bit more about yourself and the work that you do.
Yeah. Well, my name is Dr. Harvey Castro. I'm an ER board certified physician. I've been practicing almost 20 years now. I started in the main hospital systems here in Texas, and basically I honestly was not happy with the care that I was giving. I made a promise to give the best care ever, and when I was working in the regular hospital system, I felt like I was being told by management, hey, you're taking too long, or hey, why are you ordering these tests, or
right.
This test can be wait till the doctor sees his PCP or her PCP can see the patient. Why are you doing it in the ER? And then to me, it just seemed weird because I was like, hey, I signed up to be a doctor. I studied my butt off to give the best care ever. And you're telling me I can't practice medicine the way I think it's supposed to be. And it just seemed kind of weird to me. And so fast forward, I've always been kind of I want to say like a nutty professor in the sense that I've done a lot of stuff. Like I started my own vitamin company when I was in residency. I done over 30 iPhone apps, all in healthcare. I was a consultant for different companies, over 20 companies I've already started. And just, it's not for the money really. It's more for what I love, the passion, the kill, the being able to help someone. And so that really drove me to Trusted ER. And basically what it is my business partner and I were working in the main hospital. She was my nurse. I was a doctor. And we would find ourselves kind of gravitating to each other because I would say, hey, I need a nurse, but I don't want any nurse. I want you to take care of this patient because I know you're going to be empathetic. You're going to give them time. And I know this patient needs you. And then ironically, she was doing the same thing with me. She was calling me and saying, hey, I need you to go into room 2. I know you already have a bunch of patients. I know that's not even assigned to you, but this patient needs you, not any of these other doctors. And so eventually I told her jokingly, I'm like, one day we need to start our own emergency room. One day we need to just say, hey, let's build a brand.
Yeah.
because let's create something that we ironically trust, and that's what we call the trusted ER. And basically, we took all the things that we hated about the stale environment of the ER, the white walls, the just the callous feeling, and we said let's make this different. Let's create it like an upscale, nice. Doesn't feel like you're at the hospital. Let's make it feel like you're almost in your own house, real pretty, and then let's make sure that the doctors and everybody stand out. So we have the doctors not wear scrubs. We have them
Oh,
usually
wow.
dressed in a tie or dressed, like really dressed to impress. And then at night we let them wear scrubs, but during the day we want them to kind of stand out. But then we want the patient to spend time with the doctor and the doctor to be there. And I call it the noise of medicine. There's so many things out there that we just hate. One of them is if you're hurting and you have to tell your story 5 times, by the fifth
Yeah.
time you're like, oh my gosh, why isn't anyone listening? So what we do is we create everybody as a team and we walk in all together, and it's sometimes intimidating, maybe 3 4 people in the room saying what happened today so that we understand, so you don't have to repeat yourself. And so we go through all the things that we call the noise of medicine, like everybody hates their bill and doesn't understand them, so we have dedicated people that will go over your bill and explain what it is. And so to me, it just gives me that human factor saying, you know what, as a
Yeah.
doctor, I'm educating other doctors to give medicine, like the real medicine. And it's interesting. I call it untraining. We're training doctors to do medicine, but the hospital system is training them to do opposite and
Right.
reinforcing, I think, bad behavior to some degree because I get their point. They got to be quick, they got to be efficient. And to us, it's more about quality than quantity. We want
Right.
to make sure that quality is amazing. And we're blessed here in Dallas, Texas. We have something called a freestanding ER, and we're able to have an ER. Imagine like cutting out the emergency room and putting it in suburban America. That's what we're doing
Yeah. That is
basically. So
awesome.
our place is open 24/7. I mean, when you get a chance, take a look at our website and you'll see
Yeah.
our reviews are amazing. Patients come and they're like, I love that place because we take time with patients and then we take time with our team and we're educating. And then obviously doctors, nurses, the team, they come from other walks of life in the sense that they've worked at other hospitals and they've been trained to do certain things. So we literally have to untrain them before they're working with
Right.
us.
Well, I love that idea that everyone comes in together because if any of the listeners are like me, by the 95th person that comes in, I'm done telling my story. I guarantee you I will have forgotten things or I will tell it in a way that no one really believes me because I'm now insecure because I've just told this story so many times. Are they asking because they don't believe me? Are they asking because they have to? Are they asking because nobody's bothered to open the medical records? Like what's going on? So I love that model.
Yeah. I really feel blessed in the sense that I've studied my butt off. I train, I work
Right.
really hard, and now I'm trying to find like-minded people. At the end of the day, I really feel healthcare. A lot of people went into it because they really believed in doing the better good or doing something for a stranger, or just helping, and that it's in their heart. And I feel over time, especially now after COVID, all the hard work, everybody's busy, and it's just they're getting slammed. And I think there's times where they're not as caring because they've just been pushed through the system.
Oh,
And
yeah.
I want to make sure that we're rebooting the system. We're taking time with our staff. We're telling them it's okay, slow down. If you're having a bad day, it's okay to call in sick and have somebody else come in because we want to. The way I see it, the patient did nothing wrong. We're here to help, and if the staff and team is not available for the patient, then we're doing a disservice. So I'd rather the doctors, nurses stay home if they're not at their best. And I know
Sure.
that's kind of weird to say, but we want that. We want the patient to get the best experience ever.
Well, absolutely. Plus, there is such thing as caregiver burnout. And there also is such thing as, the hours are just so long that people cannot be at their best. And if people have worked a ridiculously long shift, things will, personalities will change. They'll be a little bit more irritable. People won't be at their best. They won't be thinking clearly. So I think it's really important to have it so that if you're not able to sufficiently work, now might not be a good time to come in.
Yeah. And it's hard. I get it. I get it. And there's a lot of burnout. And I try my best to balance and don't let doctors that may want to work extended period of times. I tell them, hey, you're cutting it close here, my friend. Let's take a break.
Right.
Because you don't know what's going to come through the ER. You may not be busy, but you may be busy. And
Sure.
the way I see it is we all have our moments that we're sick or we're going through something, and that's not the time for the team to feel sick and say, oh, I can't give my best. No,
Right.
we're there for the patient. And I get the whole burnout and all that, but I think as a provider, you have to take pride in your work and you have to take time. And if you don't feel like you're ready or up to it, then you need to stay home because it's not
Sure.
the patient's fault.
Absolutely. Absolutely. So let's take a few steps back and talk about how does a person know, or how should a person know when it's appropriate to go to the ER versus waiting for urgent care or to see their primary care physician.
Yeah, that's the $1 million question, and
Right?
insurance companies are really banking on this. The good thing is that in the insurance world, the definition of emergency, it really boils down to the listener right now. If that listener says, this is the worst headache of my life, yes, I get migraines, to that patient, it is an emergency. And I
Right.
would say go to the emergency room. One of the biggest fears and the reason why insurance companies, it's like a fine line they have to walk, is they don't want to say, hey, that was an emergency room and you went and that wasn't an emergency, because in the off chance that, that left shoulder pain was actually a heart attack.
Right.
And so what I always tell my family and friends is like, hey, it's hard to say what's an emergency or not because presentations are so odd. And so I say err on the side of caution, go to the emergency room. By law, I know in Texas and pretty much the whole country, they have to do a medical screening exam. And I know it's very prevalent, especially in the East Coast, that they're really strong about saying, hey, this is what's going on. I don't think it's an emergency. And sometimes some places will go as far as saying this won't be covered. If you want, wait to go
Oh,
see your
wow.
doctor, and then they'll send the patient home. I personally feel once you see the patient, if you've done all that stuff, what's the difference with just writing a script and saying, hey, this was an emergency,
Yeah.
but you're here, we did everything. Because at the time that you do the medical screening, to me, that's 90% of the work. The last
Right.
part is just the discharge and the paperwork. So then at that point, what's the difference of telling somebody to go home or go see your doctor next week? You've already done everything.
Right.
At least you have to rule out the emergency. There's some black and white stuff. Obviously, having chest pain, you're in your 50s, high risk. I would say, yeah, you need to go to the emergency room immediately. The scary part is, especially now post COVID, there's so many new diseases in the sense that there's things that people may say, oh, I didn't realize that that was COVID related. And, we're seeing more blood clots, we're seeing more, different diseases. Simple stuff now is we're seeing a lot of mental health stuff now. We're seeing more depression, more suicide.
Oh,
And so I
wow.
would hate for people not to get help or get help for any disease and wait for their doctor. So as an ER board certified doctor, I'm a little bit biased. I feel like I'm
Fair.
here and I want to see everybody and let me decide if it's an emergency or not. If it's not, then I'll let you know.
Yeah. Yeah. I mean, you definitely can't just wait around and risk somebody committing suicide or something really bad or really dangerous happen. So, yeah, wow. That's so interesting that they would do an evaluation, though, and say, no, this is not going to be covered when they've already done most of the work. It's,
Yeah,
it's
I'll
so
give you some
interesting.
black and white ones. Some of them are like a dental pain, and they go
Okay.
in, they're like, "Yeah, this is not an emergency." And but what's the difference of going in and just doing a dental block and giving them some relief and some pain meds and say, "Okay, look, it's Saturday." To me, it's an emergency because no dentist is going to see you on a Saturday night. You're probably gonna have to wait till Monday. But then you
Right.
give them some medicine, some antibiotics, some painkillers. You take care of them. You do the right thing.
Fair. Yeah, absolutely. So, in your experience, what types of chronic illnesses, and we on this podcast focus on the ones that really aren't visible. So, what kind of chronic invisible illnesses are most likely to come through the ER, especially on a more regular basis?
To me, I feel like I see a lot of diabetics, and it's very
Sure.
regional,
Okay.
depending on the
Yeah.
population that you're serving. There's some populations that have more diabetes than other. A lot of it to me seems chronic, like hypertension. You don't really feel like you have high blood pressure. You may get a headache, you may not feel right, but you don't really know unless you've been diagnosed and then you know the symptoms, then you know your body. But usually
Right.
most people don't know that they have hypertension.
Sure.
I see a lot of patients, I said diabetes first, and I do see a lot of diabetics that, either don't have access to healthcare and their diabetes are out of control, or sometimes the opposite. They have insurance, they have everything, but they just don't take their medicine. So it's kind of frustrating
Right.
as a doctor sometimes because you're like, my gosh, before this medicine existed, people were dying, and now there's an opportunity to improve and live longer.
Right.
Just do your best to take meds. But then, that's a fun part of being a doctor, is because then you get to figure out why that patient's not taking their medicine, why they're not
Absolutely.
taking that healthcare. So I think for me, the most common chronic diseases to me are diabetes, hypertension, and then just diseases of age. I'm hitting my late 40s, and as I get older, in my mind, I still think I'm 20, and I still want to do stuff like I'm 20, and I'm go, go, go. And then I'm like, man, I'm not 20 anymore. I can't stay up all night and then go up the next day. And so I feel like as you get older, your body changes. And as it starts changing, you need to be conscious that, hey, maybe the medicine needs to be changed. Maybe now I have diseases that I didn't think I had.
Right.
I personally got COVID in January, and the
I'm
last
so
6 months,
sorry.
I have been exhausted. I ended up fine, but now it's just this fatigue, and I'm like, oh my gosh, I'm so high energy, and I'm like, am I getting old, or is it just COVID, or is it both?
Oh man.
And so yeah. So just be conscious of your body, and treat your body with respect, in the sense that, take your pills, take your vitamins, get your hours of sleep, rest your mind, take time for yourself, because in the world we live in, it's so easy to just go, go, go and neglect
Oh
your
yeah.
health.
Or come see somebody like me who's either a neuropsychologist or a health psychologist, and we can help kind of make those adjustments to that chronic illness a little bit easier. What does the evaluation and treatment look like typically in the ER? I know for every condition it's different, but can you run us roughly through what that looks like?
Yeah, then again, I'm biased. I'm a New York board certified doctor. So to me, in the ER, I feel like it's the best world ever, because instead of having a patient come and say, okay, here's the script, now go to the local lab place and go get your blood drawn, and I'll get the result emailed, and then I'll find out, and then come back in a week or two, and then we'll figure out what was wrong. In the emergency room, the typical workup is now. So
Right.
I get to order the CAT scans in the middle of the night. Depending on the place I'm working, sometimes I can get an MRI. But obviously, the labs, usually have labs within 20 minutes. So I'm kind of
That's
spoiled in the
awesome.
sense that, someone comes in with XYZ, I can check everything: blood clots, heart attacks, CAT scan, x rays. And so the typical workup, I feel like I don't blame people for only going to the ER and not going to see their doctor, because, we're all so busy. The last thing you want to do is say, okay, I got to make an appointment to see my doctor. I got a
Right.
job. I can't call in sick. I'm running out of PTO. I mean, it makes sense. Like, well, heck, I
Yeah.
get off at work at 5, or get off at 7, or I work, the graveyard shift, and I'm going to go to the ER at 2 in the morning and get my stuff done. So,
Right.
and then the typical workup, I take pride in our profession. I feel like we are trained to look at emergency rooms. We are trained to rule out what's life threatening or not. I feel personal bias. I did family practice, and I did emergency medicine, so I feel like I look at the
Okay. Yeah.
whole, and I look at the ER. So I know some of my colleagues are like, nope, get them in, get them out, do it to the point and be done. I've been training my doctors. Let's look at the bigger picture, and let's, if the patient's there just for med refill, then it's okay. Give them a med refill. Don't be upset that they're in the emergency room. Like, they're a human being, and they're there, and they need that medicine. And you know what? If you don't refill it, it will become an emergency. So give them
Right.
their medicine.
Exactly.
I know there's a lot of biases that go on in the emergency room, and I know it has to do with burnout too. Some doctors are
Sure.
just tired, and they're like, "Oh my gosh, this person's been here 10 times this month. Why don't they go see their doctor?" But you know what? You're the doctor. That's not your choice. You take care of that patient.
Yeah, absolutely. And maybe a perspective shift of they're here for a med refill. Cool. This is a quick one. I can write the med refill. And that's more productivity for me. And I understand that that's not where folks are. It's the middle of the night and they're on their 8 billionth patient, and things have been frustrating and they've got a lot to work with, like a lot of different things, a lot of moving pieces. Yeah, and I know a lot of our folks are, a lot of our listeners are folks who sometimes they are in the ER several times a month with different problems, whether it's heart condition related or related to POTS or MCAS, like with anaphylaxis, or chronic pain or dislocations. We are folks who tend to be in the ER pretty often.
Yeah, I think if I think anyone that's going to the emergency room, the more data you have on yourself, the better. And let
Yes.
me elaborate. If you have your old labs, I love patients that come in with old EKGs, because I'm like, okay, here's this little blip on your EKG, and if I see it before, I'm like, okay, good, it's there before. Or if it's new, then I'm like, oh, this is a bad sign. But the more data, the more you know about yourself, the better. I love when patients come in, they're like, okay, here are my labs. Sometimes they give me like a whole encyclopedia, like they bring a whole file. It's like, here you go, doc. And I'm like, you know what? Love it. Because then they really care about their health and they want me to know every little detail, which is awesome because that just gives me more information on my patients. And I
Yeah.
wish more patients took time. I know they don't do this anymore, but I remember ice was a big thing in case of emergency. You would put it in your phone and you could, I mean, I
Right.
know Apple has some stuff in there, but I love that stuff that in case somebody comes in unconscious, I grab their phone and see if I can see anything, the medical history there, what kind of blood type, what who the power of attorney is, or whatever medical attorney and all that stuff. Like it's good. Like I like having more information because then I feel like I can give even better care. But if I don't, then I'm just kind of going blind and doing the best I can. But if I have more data, more information, then I'm going to do a much better job.
Absolutely. And that's something to the listeners that you'll hear time and again from folks is, have copies of any of the medical records that can be potentially pertinent. It's a really great way to be an advocate for yourself is just have that available. So that way you can get, first of all, people will take you seriously because then you have that hard data, but also it makes your care a lot easier. Of the conditions that you see, obviously some of them are more appropriate for an ER visit than others. Which are the most suitable for treatment in the ER and which are feasible to treat in the ER?
Yeah, there's some life-threatening emergencies that are pretty black and white. You kind of mentioned some, to me, anaphylactic shock, allergic reaction. I mean, some of these things can literally kill you, and it doesn't take much time to do so. So those are pretty black and white. I would say anytime anyone's having chest pain, especially if you have risk factors, you need to be
Okay.
checked out. The harder ones to me are like the zebras of medicine, the ones that medicine, the ones
Yes.
that we don't really see all the time. And I feel like this is where I get to teach my doctors to be humble in the sense
Right.
that, I sometimes feel like the older the doctor, it's good because they have more experience. But then that experience, if they're not careful, they're biased. And so
Right.
they're like, oh, I've seen this a million times and it's never been anything. And I read that in med school and I've never seen one. Well, guess what? Eventually, you're going to see one of those
Yeah.
cases. And eventually, that zebra's going to come in and you're going to think, oh, it's nothing. And then realize, oh, crud, this is a something. And think that's the beauty of medicine. It's an art, and that art is to be respected, and you need to do things a certain way. And if you break that system, then you're running the chance of doing some mistakes. And I'm really diligent when it comes to when I see a patient, I try to stay unbiased as much as possible. I try, even if the nurse or anyone tells me, oh, I think it's this, I try not to listen to them and come up with my own conclusion. And if it happens to be the same that I was already coming up with, great. Because I've seen it so many times that doctors go into this tunnel vision where, the red front registration nurse says X, and then another person says Y. And then all of a sudden the doctor starts going down this path and realizes, oh crap, it's the wrong path. And then they end up sending the patient home when they should have really listened. And my best advice is just listen to the patient. The
Yeah.
patient knows their body. They're not making up stuff. They're not going to say, oh, X, Y, Z. They know their body. When a patient says, hey, doc, something's wrong, they're not lying. They're telling you something's wrong. Now it's your job to figure it out. And often a lot of doctors, I don't want to say a lot, but there's some doctors out there that will ignore that and just kind of brush it, under the rug and just keep going.
Yeah, I not to give things away to for a future guest, but we have someone coming on probably in a month or two who she had some really severe cardiac issues that had not yet been diagnosed, but she knew that something was just not right. And she had gone to the ER and she was unfortunately in the ER for the 8 billionth time. And she realized that her heart rate would race really fast and then it would go down very, very low. And people were just saying, it's anxiety, get out of my ER. And she eventually was found to have a potentially fatal arrhythmia. And she ended up having, I think she had cardiac ablations, and then she ended up having a pacemaker put in. And she was only in her either late 20s or early 30s. And it was really challenging for her to get people to listen to her story because she knew something was wrong. And so
That's
it's really sad. And unfortunately, my listeners, we are the zebras. We all are the zebras. And so it's been hard for even, our primary care doctors to listen, our, specialists to listen. And then we come to the ER where they don't know us, they don't have our records, and it's challenging to get people to listen and at least attempt to take us seriously. It's really hard. So you've mentioned some things that are suitable for treatment. What for those that aren't suitable for the ER, where else or how else would you recommend these individuals seek treatment, especially if their physicians are not taking their condition seriously?
You know, again, I'm a little biased towards the ER. I just feel like doctors, we're trained to look at diseases and to look for the zebras, and that's what we're trained to do. I feel like if you truly feel that there's something wrong, I think you start with your own doctor and you explain why. And if they're not listening or working you up, then you get a second opinion, then you go to someone else. I think it goes back to psychology and biases. I think sometimes people start pegging people or categorizing them or just putting them in a box and say, oh, this is Mr. Jones and he always has X, Y, and Z. And they can never come in with a heart attack because that's not Mr. Jones. And I think, unfortunately, when that starts happening, that bias starts taking you down the
Right.
wrong path. And so I think either you need a fresh pair of eyes or you need to talk to the provider and say, hey, you need to listen to me. I know my body and I need you to take time and really, you are my doctor and I'm coming to you for help. And I think sometimes a lot of doctors, when you come to them with that angle, they're like, okay. And the other angle that I would tell you, use this line that I'm about to say. There's diseases out there that we don't know.
Right.
What if you have a disease that hasn't been diagnosed? Or what if you have a disease that is so rare that the doctor doesn't even know about?
Right.
And so, I would encourage you to call your doctor out in a polite and respectful way.
Yes, of course.
Unfortunately, some doctors have big egos, and once you go down that route, then they kind of shut off and don't they look at themselves before looking at others. And the reality is they should be doing it the other way around. They should be looking at others before they look at themselves.
Yeah. And what about for those individuals that we've mentioned who have some sort of cardiac issue and or POTS and or anaphylaxis or something like that, and or this chronic pain that sometimes gets to be horrible. I know I have, and a lot of the listeners have Ehlers-Danlos, and we can never know when our pain is going to get to the point that we cannot manage it, or we're going to dislocate something and have to go to the ER for the fifth time this month because we can't get it back in. How can we as patients work with the ER providers to make sure that we get the necessary treatment? What else should we do? What else should we bring?
That's an awesome question. I can't speak for all the doctors, but I know it helps if you're having a chronic condition that needs chronic pain medicine. Sometimes the best doctors for me as an ER doctor are the pain management doctors, because if a pain management doctor says, yes, Miss Jones is under contract, these are the pain meds, and yes, I know it seems 10 times higher than you would normally write, and that's the dose she needs, then I want the patient to put it on paper. And then if I can call the pain specialist and verify, then I'm like, you know what, then I'm 100% fine with giving higher doses that may be average to the average person, but this isn't the average person. This is a person that requires more pain medicine than the average
Right.
person. So I think bringing others, it's good. And I don't mind. I don't feel intimidated. I think it's great when a pain management doctor calls and I can verify that, in fact, it is a pain management doctor says, yeah, this particular patient needs some ketamine and Dilaudid at the same time to get them through the hump. And then once they get through that pain under control, then I'll be happy to see them in clinic tomorrow and I'll take care of them and I'll adjust their meds. And I'm like, great, because it's a team.
Right.
I don't think I know everything or claim to know everything, but then when there's another specialist, I love it. So when patients come in and say, look, this is my pain management, they've taken care of me, I've dislocated the shoulder a million times, and this is the regimen, to me, 90% of the times I'm like, yeah. And then the other 10%, I was like, well, let me do my cocktail and see. And if you're right, then yeah, maybe then I'll increase it to that to just see,
Yeah. What about for those, I know this is an experience that I've had, and I've recently been diagnosed with mast cell activation syndrome. So now I kind of understand what's going on with my body. And now that I realize that I've never had true anaphylaxis, personally, I feel more comfortable not needing to go into the ER. However, in the past, myself and a lot of the listeners, we might get chest pain that seems to come out of nowhere, really bad dizziness or confusion, trouble with breathing, things like that. And it's hard to know what's going on. Is it anxiety? Is it something really bad? Now, in the days of COVID, is it COVID? How do we know, or how can we get a sense of when it's appropriate to go to the ER, or is it always appropriate?
That's a tough question, but
It is.
you know,
It is.
I, I I would never want to hurt anyone. I would say just err on the side of caution. Don't let
Okay.
the doctor see you. Let's see what's going on. I think the more you educate the doctors, the better. I know some doctors may not want to see an encyclopedia, but I think a nice, concise page saying, "Look, these are my medical page. This is what I have. This is what my X-ray or MRI says. You know, I'm not here as a drug seeker. I'm here because I know my body, and I just want to make sure I get good taken care of." And the other thing is, if you think you're getting bad care, there's nothing wrong with saying, "Hey, I need to speak to your supervisor." If you really
Okay.
feel like you're not getting the care that you need, then it's okay. It's your body. And I always say this to my doctors, like, you're not in that person's body. To me, a 10 out of 10 is X, but to someone else, it may be a 12 out of 10. And, who
Right.
knows these scales, and some people have really high pain tolerance and
Yes.
and say, "Oh, I just have a two," but in reality, a two is freaking like a 10 for me.
Right.
So it's
Exactly.
like, take it with a grain of salt. And that's why I think it boils down to education. It boils down to listening. And I feel like the art of listening has been lost. I feel like sometimes healthcare providers kind of jump quick and say, "Okay, this is a way to do this X, Y, and Z, and I pegged you into this box, and this is what everybody in the box gets. Here you go, and go." Where in reality, every person is different. No two human beings are the same. So why would we treat each one the same? We all got to treat it differently.
Fair. So it was November, December of 2020, and I went to the ER for exactly those things. And everyone was very, very respectful. They were very nice and they tried to be really helpful, but I was sent home without any diagnosis. So they're like, "Okay, you have these symptoms. We don't know what it is. We're just going to send you home." And that was it. There was no diagnosis. There was no treatment. There was no recommended follow-up. What do you recommend in those situations for either the ER providers or for the patients?
That don't have good follow up.
That they were just, essentially the answer was, "We don't know. That's it."
Got it. Those are the most scariest patients to me when I work somebody up and I can't figure it out. And I hate telling the patient, "I don't know." What I personally tell every patient on the ones that I really don't know is, I see disease as a spectrum.
Sure.
Later, as the disease progresses and there's more symptoms, it's a lot easier to diagnose. You know your body so well that you may just be displaying a few symptoms, and it's not enough for me to like jump on and say, "Ooh, it's this disease." That doesn't mean you don't have a disease. It just means it hasn't been diagnosed.
Right.
And so what I tell my patients is, let's be hyper vigilant. Let's write down any symptoms. Let's write your vitals. Let's let me call your primary care doctor myself, and let's get on a plan to follow up in a few days. Or if you end up in the parking lot, you got discharged, and all of a sudden something else comes, and come right back. It goes back to the gestalt of the doctor, how that doctor feels. Sometimes if I have a bad feeling and I just can't find it, I'll just admit them. And I know I get hell from administration saying, "Why the hell did you put this patient in a room when you don't even know what's wrong with them?" And my answer back is, "Something's wrong with them. I just don't know what's wrong. So we need to run more tests."
Yeah.
And so when I call the hospitalist, they think I'm crazy. They're like, "Are you kidding? What are we admitting this for?" And I'm like, "I don't know, but I know something bad's gonna happen. I don't know what it is, but something."
Yeah.
And then I just got to go with that. And sometimes I sound like the crazy doctor putting people in, but I think with time, the doctors trust my judgment,
Yeah.
trust me that they don't think I'm like crazy. And they're like, "Okay, if he wants this person in, it's probably there's something there that it's scaring him and that we need to admit." So again, I think the best advocate is yourself. Interesting enough, sometimes it's weird, but sometimes when you have another party in the room, it helps because you're so sick and you're not feeling well, that if having somebody else in the room be your advocate, have the energy to fight and ask for that second opinion and ask for that. And I hate to say it that way, but you're your best advocate, but sometimes you need somebody else in the room because you're pooped out, you're tired,
Yeah.
you're done, you're dealing with your disease, you're dealing with your dislocated shoulder or something unknown, and you don't have the energy to fight. So sometimes I think it's great when somebody else is in the room. I sometimes go with my family members to the ER, or if I'm out of state or out of town or something, and I'll ask certain questions, and they're like, "What's your background?" Because they're like jumping on me, like, "What? You know too much here. What's going on?" And they start freaking out when I tell them I'm a doctor. They're like, "Oh crap! Okay, we got to
Right,
make sure we
right.
do everything." I'm like, "That's pretty sad. Like they shouldn't do that. Like they should be treating
Yeah.
like everybody the same, like amazing all the time, not." Extra special because I'm maybe a doctor and maybe this guy knows a little bit. No, treat everybody the same and you don't have to worry about that stuff ever.
Yeah, I feel like sometimes I have to pull the doctor card. Otherwise, I don't get people to take me seriously, or I I will deliberately go to the ER at one of the facilities in which I work, and then if people don't treat me well, then I disclose what I do, and then things change. And it shouldn't be that way. People should just get good care. The end.
Yeah. That's interesting. You say you have to go sometimes to your own place. What's super interesting to me is sometimes when you go to a place that you work, you either get better care or worse care. Because
Yes.
sometimes they know you so well, they're like, "Oh, I know her. I know the Dr. Castro. Yeah, he don't need any of this."
Right.
And then sometimes they're like, "Oh, Dr. Castro just walked in. Crap. I need to make sure I'm on my game. I'm gonna order everything under the sun." I'm like, "Oh my
Right.
gosh." So sometimes I like going to places that don't know me. That
Yeah.
way I know that the care I'm getting is unbiased and it's strictly subjective, which is sometimes hard to find.
Fair. Absolutely. And that leads to my next question. And this is kind of a two-way street. So what are some ways that patients can ensure more positive experience when visiting the ER, and that ER physicians can ensure a more positive experience for those patients?
Well, this is going to sound horrible again, but I'm going by human nature. You
Okay.
know, I personally think, the most riskiest times at a public hospital where there's residents, I think July 1st is probably the worst day of, you should probably go to the hospital, especially if it's a residency one, because that's the first day the residents start and they just transition from medical school to residency. And it is true, the doctors don't know. With that same logic, if you're going for something and it's change of shifts, sometimes things may get lost in translation because
Right.
you're going between one doctor to the next. And if it's busy, I hate to say this, but not at our locations, but at some other ERs, I know that they're just so running that they're just trusting whatever that other doctor assessed and they're just going by their assessment. And I'm like, what
Right.
if that's not a good doctor? What if something got missed in
Yeah.
translation? So if you want better care to me, I say go in the middle of the shift or go during low times in the ER because then they have more time. And if they have more time, then they have more time to talk to you and spend time with you and ask you those questions. If you're going, during the time where diversion, meaning, they're pushing ambulances not to that hospital because they're so busy and over capacity and all this, and then there are patients all over the place in the hallways and waiting rooms crazy busy, then and you show up, not that you're not important or an emergency, you may not get the same care as if
Right.
that, time was different and maybe they're not busy. Again, you have no control of when you have an emergency, but if you did, I would say that you'd be getting a better result.
That's really important to consider. Yeah. And what are some of the best ways that patients can communicate to the ER docs what their experience is, what they're looking for, what they're going through right now, especially if they've never worked with them before?
I love talking to my patients. I think honesty and education goes a long way. I was joking earlier when I said bring the encyclopedia. I think honestly, even if you condense all your records to one page or 2 pages and you put everything that you think is important on there and just put everything that, like, these are the key diagnoses, these are the
Mm-hmm.
things. Some doctors get upset when they say, okay, well, this is my cocktail for my migraine. I don't get upset. I'm like, thanks for giving me the heads up on your body instead of me having to
Right.
figure it out. Like, thank you. So I think a lot of it is just trust and it's just a communication thing saying, look, I am not a drug seeker. I am not, here every day because I want to. I have a true medical condition and it's XYZ. And these are my results. Here's a copy of my latest MRI. This is this. Here's my pain doctor. Here's my neurologist. This is what I have. And I need X, Y, and Z. And I'm looking for a doctor to help me through this process. And I'm willing to go through the process with you, but I need to go through it together. And I think a lot of doctors will listen and say, okay,
Okay.
well, she needs X, Y, and Z. Okay, let me do that. Or if they say, well, I don't agree with that, then you're having an open conversation. Okay, why do you not want to give me X, Y, and Z? What is it? And I think that's fair.
Okay, that's fair. So to ask those gentle follow-up questions.
Yeah.
Okay. Are there any other ways for patients to advocate for themselves if, heaven forbid, things don't go well or as hoped for or as expected in the ER?
No, I think in this particular sense, more is better in the sense that
Okay.
if you have a family member, you have someone that your spouse with you, I think it helps because it gives more information, or at least it gives validation that say, hey, my husband, my wife, whatever is validating, saying, yeah, this is not typical of Miss Jones. This is different. I think more data, the better. If you have your MRI results or certain results, I think it helps to prove like, here, look, I do have Ehlers-Danlos. I do have this disease. I'm not making it up. Like, here it
Right.
is. And I think it
Yeah.
helps. And then I think I really think it's all about communication. I think if you're just communicate with the doctor, I think the problem is, like I said earlier, the art of conversation has gone away. And I think sometimes doctors and healthcare, they're so busy that they just want to go, go, go. And I think
Right.
sometimes it's just a matter of saying, hey, here's what's going on. This is where I'm at. And let's have a conversation. And then I think a lot of doctors be like, wow, that's a different approach.
Yeah.
you know and then if you're not getting the results, then I'm totally like, call your primary care doctor. Sometimes the
Okay.
primary care doctor can call in the ER and say, oh yes, this patient has this. Yes, for some reason they only need this one drug, and if they get it, it breaks their migraine. Okay, well, thanks. Then they're like, okay, I'll take it from another doctor. And I personally, I'd rather hear it from the patient instead of having to call another doctor. But
Right.
if some doctors need to, then just know that sometimes it helps involving more people.
Yeah. And what about nowadays with COVID? I know, for example, my mom had to go to the ER a week or so ago, and my dad wasn't allowed in because, COVID precautions and things like that. What do you recommend in those cases during COVID times?
That makes me sad. Again, I'm not
Yeah.
trying to promote my ER, but we have a place well, all of our places, we don't believe in that. We're like, hey, especially if you need your loved ones to support you, and the last thing I
Yeah.
want to do is hold your loved ones from supporting you and keep them outside. If hospital policy is hospital policy, then see if another hospital ahead of time may not have that policy, so that ahead of time, oh, if I went to
Okay.
hospital B, they wouldn't
Right.
have this policy, then I won't have this issue. In the event that that does happen, and that's sad because I've heard many stories of people dying alone and not being able to see
Yeah.
their loved ones, then unfortunately, then use what you got. And what we have now is FaceTime,
Okay.
Skype. We have, other technology. And if that's all that is allowed, then use those tools, because, 20 years ago, we didn't have those tools. So
Yeah.
use what we have now, and it is what it
Okay.
is, unfortunately. It breaks my heart to know that people are passing away without their spouse or loved ones. But if it was me on my deathbed and I couldn't get a visitor, then I'd be on FaceTime and,
Oh, yeah.
chatting my whole family on that time and seeing everybody.
Yeah, I'm glad that's allowed because I wasn't sure. I know sometimes people won't allow other people on the phone or you can't record just because of confidentiality or things like that. So I personally never know, is it appropriate to have someone else on a phone or via FaceTime? So it's nice to know that that is an option.
Yeah. Yeah. And honestly, I think everything is doable. Even if policy X is policy X, I challenge everything. I'm a
Yeah.
New Yorker at heart. I would go to the supervisor. I would ask for the next person. I'd ask for their boss till I got to the president of the hospital and be like,
Yeah.
really? And then I'd get my way. If it was something I was just super passionate about, unless I thought I
Yeah.
was really harming somebody, then I probably wouldn't push it. But
Fair. And before we wrap up, is there anything else that you think our folks would benefit from knowing about anything related to ERs and ER doctor relationships or anything like that?
no, I can't overstress. The more you have and the more data you have, the better. I know sometimes if you're over prepared, some doctors may be intimidated because they're like, oh, this must be a drug seeker or something, because they are
Sure.
so prepared. But I go back to saying, just talk to the doctor. Just say, hey, I XYZ, I'm not this person or that. Don't peg me into this. I'm not being confrontational. I'm here for help. And I wouldn't be here if I didn't need help. And I think a lot of doctors and nurses at heart, they want to do the right thing. They're just unfortunately have been burned. Maybe they're burnt out, or maybe they're seeing so many
Right.
patients that are fooling them that they're just like, oh, this is the same thing, and they're probably slating you into that. But
Yeah.
No, at the end of the day, it's a profession and it's an art. And hopefully you find that doctor that practices the art the way it should be done.
Absolutely. Well, Dr. Castro, where can people find you?
I am on all the platforms. I'm on LinkedIn. Everything I made it simple. It's / Harvey Castro MD. And that's on LinkedIn, Twitter, Facebook, Instagram. I'm excited. I just wrote a book about called Success Reinvention, and it's exactly that. I feel like I come from poverty. I come from nothing, from food stamps, and my mom had me at early age and GED education. And so I am proud to be a doctor. I'm proud that where
Yeah.
I stand. And I think my mom gave me all these tools. So I put it all on paper. It's called Success Reinvention. And I made a website. It's basically harveycastromd.info. And on there, I'm doing a course on how to be successful. And next month, I'm doing a Patreon that'll come out. And it's basically like a fan page, sort of, but it's going to be helping people, giving them tools of success, what I think of the things to help you. So that's kind of what I'm doing to kind of help out in the community outside
That's
of medicine.
Yeah, that's fantastic. And I will link everyone up on the show notes and on the website as well, so everyone can access that. Excellent.
Awesome. Well, thank you so much. And feel
Thank
free to
you.
contact me. And I hope everyone's in my prayers, whatever you need. I want the best health for you, and just be the best advocate as yourself. And then let us know how we can help.
Thank you again. It's been absolutely a pleasure speaking with you. And I think this will be very, very, very helpful in ensuring that our folks can get the care that they need in the ERs. So thank you
Awesome.
again.
Thank you. Have a blessed day.
Thank you. All right, everyone. That's it for our show. Join us next time on the Spoonie Struggle. Well, that's it for our show. To find out more, join us at www.thespooniestruggle.com. That's Spoonie, SPOONIE. Check us out on Twitter, Facebook, and Instagram at The Spoonie Struggle. Please help us out by giving us 5 stars on iTunes and leave us a review so fellow Spoonies can find out what you like about us and discover their community in which to thrive. See you next time on The Spoonie Struggle.